Guys, welcome back. We're going to jump right on into video number 2, where we're going to talk about initiating and advancing insulin. Now, before we get started, I want to make sure that you have your algorithms handy from the AACE and the ADA. I'm going to be referring back to them, and I'll be honest with you. I tend to lean more towards AACE than ADA. And the reason being is because I think the algorithm is more detailed. And for me, when it comes to insulin, I want to have as much detail as I can have. Now, these two boards, these governing boards, they actually collaborate a lot together. So you can't go wrong with either one. It's really a personal preference. You'll be covered in either situation. But I just wanted to let you know that as I'm talking, you'll probably see that I'm going to be talking more in depth because I'm going a little bit more off of the AACE's algorithm. Now, something to consider and keep in mind, not only for you, but also so you would be able to educate your patients, is that diabetes type 2 is a progressive disease, okay? If there is not a committed lifestyle change that's of big significance, okay, eventually patients will have to start on insulin because of the nature of the disease and how it evolves over time, okay? And there are patients, even with a great effort with lifestyle modifications, they'll still be on medications. And we know that, guys. Like, people can lose a lot of weight, they can exercise every day, change their diet, all those things. And because of people's genetic makeup, they'll still have to be on medications. That goes for any medication, blood pressure, hyperlipidemia medicines, all those things. You have to start educating your patients over that and normalize it for them. People are afraid of needles. They're afraid of insulin. A lot of people feel like if they're on insulin, they have failed. They have failed at something. And we want to empower our patients. We want them to be a part of their plan of care because that's really the only way that we're going to be able to succeed and they're going to be able to succeed with their glycemic control. So we want to start early explaining these things to them. You don't want to be a Debbie Downer. You don't want to be negative, but we want to empower them. We want to make sure that they are educated on what is before them and what could be before them. And hopefully that would motivate a lot of people to really invest in their health. Your clinical approach to insulin dosages, it's really going to have to take into account a lot of factors, okay? You do need to keep in mind what kind of diabetes they have. What type do they have? Is it type 1? Is it type 2? Gestational? And there's other forms out there. You want to keep that in mind. You also want to think about their physical activity. Now, we know that if you have an active patient and they're out there exercising, that's going to drop the glucose, and so we're going to have to adjust the insulin dosage accordingly. Same with meals. I read an article that said that the average American eats about 2 meals a day. Like, we need to know those things. We need to know the patterns of their diet. We need to know those things so we can adjust the insulin appropriately. You also want to keep in mind the patient's preferences. Again, I talked about needles earlier. Maybe having a demo pen where you can show your patient how small that needle is, going through demonstrations and having it returned, and then also keeping in mind their dexterity. Are they going to be able to draw up the insulin? How's their vision? Are they going to be able to see the different notches, the different ticks on the pen or on the syringe? We have to keep those things in mind. Also, guys, we want to think about the degree of insulin resistance. Now, to be quite honest with you, for the type 2 diabetic, a lot of times by the time they are put on insulin, their insulin resistance is rather high, okay? And so what you put them on, that total daily dosage, which is the TDD, is going to probably be ultimately high for them because you're going to have to really front load a lot of insulin to get that glycemic control in control, okay? Something to consider as well is your A1C as well as your home readings as well, the patient's home readings. We should be encouraging our patients to be taking their blood sugar at home regularly. This never stops, okay? If they're on insulin, they need to be checking their blood sugar every single day, okay? Even if they're at goal, because things can change. And we need to be able to see the highs and the lows, especially the lows. And your patient needs to know when they're low so they can also be able to anticipate and to compensate during those times. Now, with your readings, what you want to think about is which glucose level is not at goal. Is it the fasting or is it the prandial? These are the things that are going to help guide us in our approach to our insulin dosage.